All right. Once I get shared here, if you guys would just let me know you can see my screen. All good?
Yep.
Perfect. All right. And, there's going to be some stuff we're going to kind of move through because it's knowledge you already have as far as assessing somebody with abdominal pain, but some slides we might take a little bit more time on. Obviously, any sort of abdominal pain, abdominal problems, constipation, any sort of GI bleed, these all fall under gastroenterology. When we talk about different calls that we go on throughout the year, as you can see, some of the statistics there that we deal with on a yearly basis. Think of the calls that you guys randomly go on. It's kind of a higher number than you would think. As far as GI problems or abdominal problems or even bleeding, we're going to see more GI bleeding when we start getting into our specific diseases, such as like ulcerative colitis, Crohn's disease, or maybe even some sort of traumatic injury that has caused a bleed. So the abdomen is kind of scary just because it truly can hold a lot of blood before you start to see any true signs of it, before you start to really see any bruising. So just something to think of when you think of traumatic injuries or maybe an injury that somebody sustained. So always consider your mechanism when we start talking about that, not to get to trauma or anything like that. But a lot of GI problems stem from diet, stem from hereditary issues. Especially people that have some of those diseases I mentioned earlier, Crohn's disease, maybe IBS. Those people really have to watch what they're eating just because their GI tract is very sensitive to what it is digesting. And some of the things that can put those people at risk for potential GI problems are the things you see listed on your screen there. One of the bigger ones being excessive alcohol consumption, just because that acid from the alcohol does a number on our GI system and our digestive tract. Excessive smoking, increased stress. Remember, our GI tract is still fed with blood. It's still a muscle. Our mesenteric arteries are what supply blood flow to our GI tract. So any sort of stress, any sort of potential injury or ischemia, if you will, to those mesenteric arteries can lead to some longer term problems down the road with our patients having abdominal problems or whatever. Ingesting of caustic substances. So maybe it's a toxin such as drain cleaner. I brought up some people that would drink antifreeze in lower increments just to try to get that alcohol feeling. And then obviously any sort of poor bowel habits. And that falls back in line with dieting and making sure that you're eating foods that are good, whole, full of nutrients, as opposed to eating greasy, nasty foods all the time. That really starts to wreak a havoc on your body. I would probably know these different classifications of pain, National Registry wise. So we've got visceral, somatic, and referred, and we're going to go through each one. But again, visceral, somatic, and referred for different types of pain. Visceral pain is any pain that originates in a hollow organ. For example, things they have listed there: gallbladder, appendix, even your stomach is a hollow organ, unless obviously it's filled with food or anything like that. As to where your liver, kidneys, those are going to be more solid organs, right? They don't house anything. They're essentially a big muscle. They're really dense. So anytime we talk about visceral pain, we're looking at, think of appendix pain. That's a good example of visceral pain. So somebody having maybe an acute onset of appendicitis is going to have that really sharp, almost stabbing or tearing like sensation in the lower right quadrant of their abdomen, just because that's where their appendix, or that's where the pain is generally going to prevent itself. Depending on the position the patient could be in is also going to determine the pain level. Some patients might lean forward because it provides some relief to them, as to where sprawling out or laying backwards is going to cause more pain just because they're stretching. That's why you'll see a lot of patients with abdominal pain kind of almost in the fetal position, just because it's more comfortable for them. Appendicitis is going to be something you see come up multiple times in here. And a big reason for it is because it is something that we can't necessarily diagnose in the field, but we can have a good idea. Again, somebody has that right lower abdominal pain, right lower quadrant, and it's sharp, tearing, they still have their appendix. Yeah, I'm going to start leaning towards possibly appendicitis. With visceral pain, one of the things that can also cause this is inflammation, possibly due to infection. Um, Another terrifying part of that is a hollow organ can tear like a balloon. Think of, when you inflate a balloon too much, what happens after a period of time? The walls weaken and the balloon can eventually rupture. It's very similar with our hollow organs. And what you're feeling with that pain, that hollow organ pain, that visceral pain, is essentially that stretching of the muscle itself, of the outer part of your organ. Somatic pain, this would be, I'm trying to think of a good example that this could okay, say a 16-year-old calls for abdominal pain, not sure what's going on, and he can't pinpoint the pain. It's more just a generalized abdominal pain. It could be caused by something he ate, could be caused by something he drank. This is a pain that isn't necessarily pinpointed. It essentially, where's your pain at? Okay, just my whole stomach hurts. I don't know what's going on. My whole lower abdomen hurts. That's more of a somatic pain. It can be localized to the region of the abdomen, but it can't be localized to a specific organ. And then referred pain. One of the things we talk about and we'll get into here is gallbladder pain. Cholecystitis is anything you see chole, CHOLE, refers to your gallbladder. People that eat really fatty meals, really high in fat contents, bad fats, I should say, can develop gallbladder pain. One of the things with gallbladder pain is that you can get right shoulder pain as well. It's called Kerr's sign. That is considered referred pain. Kind of like, think cardiac. Where's the referred pain at? Sometimes they can have referred pain in their jaw. Sometimes they can have referred pain in their left arm. When I think of referred, I think of pain that's radiated at that point. Where one of the questions we ask is, does this pain move anywhere? We're asking necessarily about referred pain. So remember, your visceral, somatic, and referred pains. Visceral obviously can be pinpointed, more of a hollow organ pain, more of that stretching. Somatic is more of a regional type pain. Okay, my abdomen hurts. As to where referred is, where is the pain radiating to? Easiest way that I remember where different parts of my organs are, where my different organs are in my abdomen. This isn't necessarily a picture I'm looking for, but this is a good example that I can use because it's a person. Is your abdomen is broken down into 4 quadrants. So we've got right upper, left upper, right lower. Jeez, that's horrible. Left lower. Easy way I remember it is glass. So talking about my right side over to my left, G, L, A, S, and S. So my G is obviously gallbladder. That'd be more of a right upper. L being liver. That's more of a right in the middle between the right upper and the right lower. You can also feel it on the left side as well. Lower right, A is for appendix. Upper left, spleen. And then you have your stomach as well. That's how I remember where my organs are at. If you want to throw in pancreas there, you can. You would just throw a P at the end of the glass for your pancreas. I'm not saying those organs are in that exact order, but where they sit primarily is on that side. So remember, gallbladder, liver, appendix are more on your right side, as where spleen and stomach. A majority of the stomach will actually sit on your left, along with your pancreas. One of the big things to bring up here as well is obviously any sort of pain around the either flanks or lower to mid back could also be kidney pain. It doesn't necessarily have to be a back injury or anything like that. It could be renal pain, kidney stones, maybe a kidney infection, maybe, drinking high contents of syrups, a lot of pops, and your body's just not able to filter it like it should. you can develop pain in your lower back, not necessarily back pain, but more kidney pain. But kind of a good diagram, kind of a cool diagram when people talk about different types of referred pain. There's actually an example there, right shoulder pain, liver, appendicitis, heart obviously radiates down the left side, and then renal pain, lower back. I would say that if you think it's abdominal pain, the only thing that we incorporate with a trauma assessment is looking. It doesn't hurt to look and see if somebody's abdomen is distended, if there's any sort of bruising, to indicate maybe there is a bleed, maybe their appendix is ruptured, maybe they've got a perfed bowel, whatever it might be. Also palpating their abdomen. Generally, the area that hurts the most should be the area that you palpate last, because if you palpate it first, you're going to spread that pain all throughout their abdomen, and no matter where you push, it's going to hurt. So the area they say is the most painful should be the last place that you are actually going to be palpating. Obviously, it should go without saying. Look for I call it evidence. Look for different things that could indicate what the problem is with the patient. Is it a really ran down house that isn't really well kept? There's alcohol containers everywhere. There's, pizza boxes everywhere, and they're complaining of abdominal pain. Okay, they don't live the healthiest lifestyle. That for me, again, is a smoking gun or a red flag for things I might start to consider. Also, if they have thrown up or have complained about throwing up, I know it sounds nasty. One of the things I want to do is if they have it, I want to see it, because I want to see if there's blood in it. And I also want to see what color it is, because it's going to make a difference as to what I think is going on with the patient. I know that sounds nasty. I hate doing it, but just something to consider. Is it truly a medical or is it a trauma? People can have abdominal pain for a couple weeks after they potentially obtain an injury to their abdomen. Again, the abdomen, it makes up a large portion of our body. It can be injured rather easily. Take the patient's age into consideration. Are they potentially a fall risk? Is it somebody that maybe has a cracked rib? Is it somebody that's younger, maybe was involved in an altercation? Things like that. Another thing with your abdomen, and I know we brought it up at one point in time, is if you feel that pulsating mass in the lower abdomen, like around the belly button or umbilicus, maybe they have a aortic aneurysm of some sort. Just some things to watch out for. Again, the abdomen can hide all sorts of stuff. Obviously, it goes without saying we should be asking about our sample history with all of our patients. One of the big things that stick out to me here is I want to know medications, especially if there are any new ones that could potentially be causing some abdominal issues. Antidepressants, anxiety, ADHD medication are known for causing abdominal problems. I want to know what medical history they do have. Has anything like this happened before? And what was the last thing they ate? Those are the pertinent things to me when I'm going through my sample history, because they're going to make a difference in the next questions that I ask the patient. OPQRST, obviously it's going to run you through this onset. How long has this been going on? Base it around what the patient is complaining of. Don't just, okay, when did this start? Does anything make it better or worse? Don't be a robot. Okay, when did this start? Can you tell me a little bit about it? Was anything out of the ordinary when this started? Or was everything normal for you? When I think of better or worse, okay, does the position you get in make it any better or worse? Have you had pain like this before? What did you do to help the pain at that point? Quality, again, tearing pain for me is scary. Tearing pain can indicate an abdominal aneurysm. It could indicate appendicitis or a ruptured appendix. It could indicate a perforated bowel. As to more of a dull, achy pain, could be something as simple as constipation. As to where, again, pain in your lower back and in your flanks, your sides, could be kidney stones. Treat these people if they have pain. I don't care what kind of pain they're complaining of. You'll know if they're in pain. Heart rate's going to be elevated. They might be sweating a little bit. You'll know when you see them if they're truly in pain or not. Where does the pain move to? Where's that referred pain at? Know some of your referred pain locations. Don't ask them that specifically, but know what they're potentially going to say. Okay, if I'm having appendix problems, yeah, my right lower abdomen really hurts, or my right shoulder really hurts. That's okay. That leans me towards liver problems or gallbladder problems. I'm not saying, hey, does your right shoulder hurt? Because either A, they're going to agree with me just to um, get through me talking to them, or they're going to look at me like I'm nuts. Have them describe where the pain is. Don't give them clues. And what does the pain feel like? On a scale of 1 to 10, 10 being the worst pain you've ever felt in your life. For women, I would say 10 is you're giving birth again. What would you rate this pain? Generally, if they're truly honest, it could fall on average. I don't know why it falls at 5 or 6 usually. If they're like, oh God, it's a 50 out of 10. Okay. Again, have you vomited recently? And if so, was there any blood in it, or do you notice any discoloration? Same thing with bowel movements. Do you notice any blood or things abnormal? I don't want to see any of that. I just want to know if things weren't normal to them. Were they having diarrhea? Those are things to consider. This can be pretty big as well. Have they been eating regularly? That could fall back to medications. I recently, I'd say within the last couple of months, was put on medication as well, and my appetite diminished severely. So what happened after that is, yeah, my stomach would ache and groan because I just wasn't as hungry as I used to be. I wasn't eating as much as I used to. So yeah, my stomach had to adjust. My abdomen I'd have pain every now and then. Just things to consider. Not every emergency is a true emergency, but we should be asking questions to put us down the right path. Common things that we can see, because abdominal pain, remember, those patients were potentially putting 12 leads on, because some of those might present like a cardiac problem. Maybe they have some sort of acid reflux. Maybe they have an ulcer. Maybe they have cholecystitis or gallbladder disease. The most common one we will run into is acid reflux, GERD. Generally, when patients go through their medication, they might say they're taking omeprazole, or they're taking uh, some other medication to help with that. I know I get really bad acid reflux if I drink orange juice or anything high in acid. And I recently just developed that in the last couple of years. Does that mean I think I'm having a heart attack every time? No, but I'm obviously educated in this. Somebody might not be that's calling 911. So remember, I told you the story about the person that ate hot wings at 3 in the morning, or at midnight, called at 3 in the morning, said they were having the worst chest pain of their life. Well, yeah, you ate, blazing hot wings at midnight. I'd be having the worst chest pain in my life too. And they're also probably gonna be having abdominal pain. So looking for your different assessment findings, looking for things that you can consider in the back of your mind. Again, that's what makes us a paramedic. Look at their abdomen. I can't preach that enough. Somebody's having abdominal pain. It doesn't hurt to look at somebody's stomach. It doesn't hurt for you to feel their stomach. Does it feel hard to you? Does it feel distended? Does it feel soft? Don't just put in your report abdomen soft, non-tender. Come on, do your job. Do your assessment appropriately. You'll know if somebody's abdomen is distended because it'll almost appear like they're poking out their stomach. And again, something to consider as well is, have they had normal bowel movements? Could this be a case of constipation? It absolutely could. This is a big national registry thing. Cullen's sign and Gray-Turner sign. Cullen's sign is bruising around the belly button or umbilicus. Gray-Turner sign is bruising on the flanks, on the sides. So if we get any sort of bruising around the umbilicus or belly button, it could indicate an organ has ruptured, or maybe appendicitis. As to where Gray-Turner sign as well could be appendicitis, but could also be a kidney issue. Please remember, colon sign, umbilical, Gray-Turner sign is in our flank. I don't so much as listen to people's abdomen. Going through paramedic school, that was something we did. We would listen to people's abdominal sounds. we were listening for like what a bubbling or a gurgling, because that would indicate that their digestive tract is moving, that it's doing its job. You know, our digestive tract, our small and large intestine, uh, have muscles. They have to move food from the beginning to the end, and they do so by a process called peristalsis. And peristalsis is almost like if you've ever watched a caterpillar how it crawls across the ground. That's essentially what our large and small intestines do. Kind of like, a slinky. They'll shrivel up and then they'll expand, shrivel up and expand to slowly pass food down our digestive tract. Again, when we're palpating, the area that hurts the most, or the area they tell you that hurts the most, should be the last place you palpate. Palpate everything, and then that one last. I do it right upper quadrant, right lower, left upper. Um, I'll tell you, when it comes to these patients, they're probably going to be experiencing nausea. They're probably going to be potentially vomiting. Have your emesis bag ready. It's not going to hurt to give them, 4 milligrams of Zofran to help with their nausea. Um, yeah, be prepared to suction. Maybe if there's a potential for your patient to go unresponsive. If there's a potential for your patient to go unresponsive, we might have a little bit bigger issues than what we truly think is going on. Some people can experience so much pain that they essentially pass out. So just be cognizant of that as well. And again, if you need to give your patients pain meds, give them pain meds. There's nothing wrong with that. It's abdominal pain. We're probably going to be putting them on a monitor no matter what. Might as well give them pain meds. This I don't necessarily agree with, and it's been told I don't know how many times to me, and even physicians, you might hear it brought up, is avoid masking abdominal pain by giving pain meds, because when they get to the hospital, when they go to do their assessment, they're not truly going to be able to tell how bad the issue is. I hate to be this way. That's their problem, not mine. My problem is to treat the patient, and if they're complaining of abdominal pain, I'm going to treat the pain. Yeah, I try to do things with my patient's best care in mind. And at the time, my patient's best care is reducing their pain. Again, this patient might be comfortable in the fetal position. I've transported patients before in the fetal position. You just strap them in as best you could. Am I saying that's right? No. But it's what I have to do to prevent my patient from freaking out. This could also be the patients that you're giving pain meds inside their home prior to moving them. You're probably not going to be asking these people to walk if the pain's that severe. You might be actually lifting them up and bringing them to the cot just so they can keep that pressure on their stomach, or stay in the hunched over position so they don't have that severe abdominal pain. Um, Obviously, when they get to the hospital, they're going to undergo a CT, different types of imaging labs to determine if there is any sort of bleed or what the potential abdominal emergency we're really dealing with at that point. Our GI tract doesn't just contain our large and small intestines. Some of the organs that play a role in that, obviously, your liver, which is going to be filtering any sort of bile and creating bile as well. Gallbladder is going to be storing some of that bile. Gallbladder is kind of, I hate to say this, kind of useless. Pancreas is going to help us with insulin and hormone retention. And then obviously your appendix. Again, I hate to be this way. It's kind of a useless organ. That's why people get their appendix removed. What our GI tract is doing is when food is brought into our system, it is robbing the nutrients from it. So if you read those nutritional facts in the back of, well, I don't know, a thing of beef jerky, or on the back of a thing of Skittles, those are the different macros that are in that package, and those are the nutrients that our body kind of steals from it. Obviously, any sugars convert to complex carbs. Complex carbs over time turn into fat, as were simple sugars, such as fruits, will not. Our body is able to burn those a little bit faster. If you want to go over every bit of this diagram, you're more than welcome. It's just showing where our GI tract begins and ends, from our mouth all the way down to the rectum, and everything that food and nutrients is going to be touching on the way down. Our upper GI tract does start at our mouth and ends at the beginning of the small intestine. You'll see that word duodenum. That is the beginning of our small intestine. So everything from our mouth, our esophagus, stomach, down to the beginning of the small intestine is considered upper. Everything from there down is considered lower. Upper is going to take a majority of the nutrients out of the foods that we're eating or things that we're drinking. As to where our lower GI tract is going to essentially almost do like a secondary survey over all the nutrients passing by and see if there's anything that was missed. And then it'll work on excretion of that food into waste. Upper GI, this goes back to EMT level stuff. If we have an upper GI bleed, this could potentially be, dark in color. We're talking about GI bleeds. We'll see patients that have really dark tarry stools. That's just because the blood is having to pass all the way through the lower GI tract before it is essentially exposed. As opposed to our lower GI tract bleed, we're going to see more of a bright red bleed when it comes to that. Mallory-Weiss tears, please, that's something to remember as well. That's when you have an esophageal lac or esophageal laceration. Huge concern, absolutely. Huge emergency, yes. Those can be caused by a number of different issues, especially esophagus breakdown due to high acid contents, due to prolonged vomiting, prolonged alcohol intake, as well as esophageal varices, which we'll get into here shortly. Some key words to remember here. Hematomesis is bloody vomit, so emesis bag. Anything which HEM is generally blood, or hemat, think of like hematocrit. So that's bloody vomit. As to where if it passes through the lower GI tract, we're going to see that bright red blood, or if it passes through the lower GI tract, we're going to see dark tarry. If it presents in the lower GI, we're going to see bright tarry blood stool. If a person's vomit contains massive amount of blood, to me, that's an emergency. Again, there's a number of things that could be causing it, from a stomach tear, anything in their upper GI tract, again, mouth, esophagus, stomach, beginning of the small intestine. Chronic alcoholics get what's called esophageal varices. What that is due to hardening of the liver, blood begins to back up. And when it does, it essentially forms these pockets in our esophagus. And the fear is that if one of these pockets ruptures, they can get esophageal bleeding. And then it starts to drain into their stomach, and it's a bad deal all the way around. Monitor your patients for shock, especially with potential abdominal injuries. Again, remember, the abdomen can hide a lot of blood. So we're not 100% sure what's truly going on, but we can tell based off of looking and feeling. Do we have a distended abdomen? Do we have a really bruised abdomen? What's going on? If you need to do orthostatic vitals, take a set of blood pressure, a set of vitals while the patient's sitting, have them stand up, repeat the vital signs, have them lay down, all those different positions to see if there is a change. Depending on the protocols you look at, they'll say anything greater than 20-point drop in systolic blood pressure indicates orthostatic vitals, which could be an indicator of shock or the patient's dehydrated. Some of those common things we're going to see with these abdominal injuries, obviously general weakness, potential fainting that could be due to a bleed or due to the patient in so much pain again that they feel lightheaded, they're going to pass out. If somebody's truly having an abdominal emergency, you'll notice that they'll generally be really pale in color, almost like a cardiac patient. They'll be really sweaty. That's a really good indicator the patient's potentially treading that shock line. All right, I spoke a little bit about this, or esophageal varices. Again, due to a large consumption, mostly due to alcohol. You'll see this in chronic alcoholics. I've never seen it, to be honest. I don't really know if I know 100% anybody that has. Their liver begins to harden due to the massive amounts of alcohol. They get these backup of veins into the esophagus. These essentially are eventually rupture, causing a bleed within the esophagus itself. They start to drain to the stomach. So they'll start to pass dark, tarry stools and they'll begin vomiting up blood. It's just not a good central illness. Again, alcohol liver counts for 2/3 of these cases. It brought up caustic substances, and when I think of caustic substances, again, I think of drain cleaner. I can't think of a time that I honestly truly was on a patient that drank drain cleaner unless it was a child that accidentally got into it. Whenever you hear of esophageal varices, and this goes for National Registry as well, think chronic alcoholism. And again, it says here focus on aggressive airway management. That's due to the fact that we've now got a bleed. This patient's going to be coughing up blood. They're going to be vomiting up blood. Airway is a concern at this point. And I hate, I watched, God, it was a case study or something like that they said, intubating these patients could actually slow the blood flow because you're inflating the balloon. It's going to push against their esophagus. You might be able to slow the bleed down. But again, unless you truly need to intubate these patients, don't just be wildly throwing tubes at people. I wouldn't place too much remembrance on this octreotide. I've never even honestly heard of it prior to reviewing this slide, so don't even, I wouldn't remember anything with that if I were you. Don't put too much effort into that. Example of our esophageal varices, you see these veins backed up, swollen, that eventually lead to them rupturing. And again, this is draining into their stomach, causing them to vomit up blood. Gastroenteritis, so inflammation of the stomach or the intestines due to, it could be an infection, it could be something you ate, something that didn't agree with your body. These patients are generally, going to be vomiting or having severe diarrhea. Since I switched medications, I've been trying to eat better foods. And I've noticed that if I eat something that's not the best for me, my stomach starts to hurt really bad. I start to have really bad stomach pains. I might have to use the bathroom more than normal. That's a really good example of an acute gastroenteritis instance that is just causing your essential stomach and intestines to kind of freak out a little bit. They're not used to what it is and they're trying to get rid of it, is a good way of putting it. Alcohol and tobacco, you're going to see that in any abdominal emergency that we're talking about. Tobacco, more or less, believe it or not, people that chew tobacco are more at risk, just for the simple fact that, again, it's very acidic, has very high concentrations of nicotine, very high concentrations of things that aren't great for us. Whether you chew tobacco or not, or you spit into a cup, whatever, some of that is draining into your stomach at all times, and eventually wreaks havoc again on our GI tract. Another one, aspirin. Long-term prolonged use of aspirin can begin to break down the GI tract. That's why one of the things that we always want to consider, or that we ask when we're going to give aspirin to somebody, hey, have you had any recent GI bleed? It's just for that example, because it'll break down the GI tract faster than anything else. So the GI bleed is more of our concern when we're potentially going to give aspirin to a patient. Be careful with patients that have severe diarrhea. I don't mean be careful like, they're going to essentially make a mess of the back of your ambulance. Be careful for the simple fact that if this has been happening for a prolonged period of time, these patients could be hypovolemic. They could have lower blood pressure. They could be very ill. They could honestly be presenting with that pale, ghostly white color just because, again, they're trending shock. If you need to aggressively manage these people with fluids, by all means, it doesn't hurt anybody to start an IV and give them fluids. And if they start coming to, or their condition starts to better, just slow the fluids down. Not a big deal. Treatment is going to revolve around treating our patient's symptoms. What are they complaining of? What can we do to relieve the issues that the patient is having at that time? Chronic gastroenteritis, instead of acute onset, this is going to be more of a essentially a bacteria that lives in the GI tract that could disagree with all sorts of different types of food. It could disagree with everything that you're eating, causing that severe diarrhea, that severe vomiting. Patients can actually develop a fever due to their body trying to fight this infection. Again, it's due to that H. pylori that you see there, that bacteria that lives in the GI tract. And honestly, these people, we talked about this last week, I believe. The antibiotics, prolonged antibiotics use can cause this as well. This is where we see the patient's long-term health facility, long-term antibiotic use start to develop this bacteria within their intestinal tract, similar to C. diff, that essentially gives them vomiting, diarrhea, leads to them being severely dehydrated. Ulcers, one thing you always hear, you think is funny, is people talk about being stressed and developing an ulcer. Generally caused by gastric acid. This also plays a role in what you eat. That's why people with ulcers have to be careful of eating really fatty foods, pizzas, hamburgers that are really high in fat contents or really high in grease, just because that ulcer can act up. And what'll happen over time is that ulcer can begin to bleed, and they'll have really bad stomach pain. They could essentially have heartburn as well. That's why with these, one of the things they highlight is patients' last oral intake, because you want to know what they ate. If there's a chance that they ate something that could have flared up an ulcer, yeah, that's something to consider. It's something we kind of want to know. Examples of our ulcers, you can see those they almost look like little blood cells there. They're essentially sores that will become inflamed if certain acids, start to wear them down. They're really sensitive areas within our GI tract that are really sensitive to acid. So almost like a scab. And then when acid hits it, that scab starts to run off, and we can start to see these ulcers bleed or flare up or become inflamed. um, Again, some of the things we could potentially see causing ulcers, or I would say not causing, but causing more issues with ulcers. NSAIDs, be careful of them. Aspirin, ibuprofen, naproxen. Again, when I took a massive amount of ibuprofen, I was having really bad stomach problems. I was having really bad stomach pain. And one of the things my doctor had told me was be careful because you can develop an ulcer from that, or that H. pylori bacteria, similar to what we would see again in the long-term care settings. Most people with ulcers, if they know they have an ulcer, you'll know that they'll carry, some sort of antacid with them, Tums, whatever it might be, Pepto-Bismol, just to treat that if it was to ever flare up. All right, let's take a 6-minute break and we'll come back. And I think we're halfway through this slideshow, so we'll finish the other half and should be out of here by 7:30, guys. All right. Jumping into our lower GI. So obviously our upper mouth to small intestine, lower is going to be small intestine to the rectum. Large intestine is where small intestine is, I guess, where a lot of our nutrients are absorbed. Large intestines is going to continue to steal nutrients as well as absorb any water that it can pull from any of the fluids. And then it's going to turn everything else into waste to get rid of. So remember, small intestine, nutrients alone, large intestine, nutrients and water, as well as forming waste. I'm not going to hit a whole lot on GI bleeding just because I feel like I've been talking about it a couple times. Some things that can cause GI bleeding, obviously, some of the most common ones are any sort of IBS or irritable bowel syndrome, bowel disorders such as ulcerative colitis, Crohn's disease. Again, those people have to be very careful of what they're eating and generally have to be on a long-term medication to help them control any sort of bleeding or any sort of inflammation that they may develop just due to what they are potentially eating. Most common things we'll see with lower GI problems is like severe stomach cramping, nausea, vomiting. Again, treat their pain, treat them with some Zofran. Changes in stool habits, I will say. If we went from solid to diarrhea or vice versa, that indicates that generally something is going on. I've been on, and I'm guessing, I don't know if anybody has before, when I used to do interfacility transfers or when I worked at solely in EMS service, lower GI bleeds that were pretty severe. And when I talk severe, like they were active, not like you would think of, dark tarry stool or like just a little blood in any stool. This was like severe active bleeding, where they would have to go in and essentially have surgery. And again, if you've been on GI bleed, you know the smell that I'm talking about. It's horrible. I can't. I get sick just even talking about it. Those patients potentially need fluid resuscitation. Again, you're not treating them with blood, and you almost treat it like a trauma situation. Blood pressure 90, 100 systolic is what I'm trying to keep them at. Because again, I'm not trying to wash away any clots. Ulcerative colitis, I know I've said a couple times, it goes in line with kind of, in my opinion, IBS, irritable bowel syndrome. It is caused by an inflammation of the bowels. And again, some foods, some food groups, pasta sauce, it could be different types of creams, it could be anything that could essentially inflame their bowels when essentially it is touched. Just some things to watch out for. These people, again, need long-term medications. Assessment wise, they're going to be able to tell you more about their disease than you will, just because they've probably had it for a pretty long time. If anybody in here has, you don't have to say, but then you know what I'm talking about. You know, you've been educated on it by your physician, and know what you should and should not eat and what you should and should not do when it comes to what you're essentially putting in your body.
Yeah, I have one question for you.
Yeah, go for it.
Is that different than diverticulitis? Is that caused by nuts too, or no?
No, diverticulitis is a little bit different.
Okay.
We might actually, I'm pretty sure diverticulitis is on here.
Okay.
So we'll get to it. Again, most of the time, these people will know when their ulcerative colitis is acting up just based off what they're eating. Sometimes if they eat something they don't agree with, they're either going to vomit it up or they're going to have severe diarrhea. These people, again, will undergo probably severe weight loss because they have to change their whole eating habit, their whole diet habit, just because of things that they can and cannot take into their body now. Kind of example, there's your inflamed spots of the large intestine. You can see they're almost like sores, essentially, that when certain nutrients or certain ingredients or certain whatever they might be within food inflame those, they get those really severe cramping. They can have bleeding, vomiting, diarrhea. What you'll notice about some of these is they're all pretty much, I wouldn't say the same, but when we talk about inflammatory bowel disorders, such as Crohn's disease as well, um, a lot of it is hereditary and a lot of it has to do with what they're eating, unfortunately. A lot of people, this doesn't get diagnosed till later on. They've had the problem their whole life, but they decide to go to a doctor because, they're a little bit older. They want to figure out what's going on. And then they're diagnosed with Crohn's disease or ulcerative colitis or have an ulcer or whatever it might be. Obviously, With Crohn's disease, it's going to be very similar as well. You're not going to have as much bleeding as with Crohn's disease. This is more of just inflammation and severe stomach cramping, severe nausea, vomiting, diarrhea. Essentially, you're not going to really see that blood. Um, Crohn's disease can mimic a obstruction, a bowel obstruction. But the problem is the thing that kind of tells the difference between the two is with Crohn's disease, they're probably going to be using the bathroom more often than not, as opposed to a bowel obstruction. They're probably not going to be using the bathroom. And especially if they have a severe bowel obstruction or like an impacted bowel, they're going to become pretty sick pretty quickly because that waste is building up inside them. Oop, there we go. Diverticulitis and diverticulosis. So it's actually, oh, what's the best way? I actually had a friend that had diverticulitis uh, not that long ago, and it was due to eating, I want to say, vegetables that contain some bacteria in it, if I remember right. He was actually in the hospital for a little bit of time, 3 or 4 days, due to that tissue breakdown of his intestines. You'll see here it talks about like mucosal tissue, submucosal tissue of the intestines. Um, Bad fruits, bad veggies can lead you to diverticulitis. If you've ever had diverticulitis, it is horrible pain to deal with. It's almost like severe cramping, stomach cramping 24/7 that you can't get rid of because your muscle or your intestines are a muscle in themselves. So it really is cramping. But it's generally caused by um, a bacteria that leads to an infection that's actually causing inflammation within these bowels. Um, when I say inflammation, when I say infection, these people are going to present like that. You can see here fever, increased WBC, white blood cell counts, just because their body's fighting an infection. Tenderness on palpation. Generally, some of the things that they're going to do is obviously treat it with antibiotics because it's a bacteria that's causing this. So antibiotics should be able to clear it up after a period of time. We just want to prevent that prolonged antibiotic use because, again, that can lead to other severe GI problems. Diverticulitis, I actually looked this one up earlier. Again, bacteria that can be found in bad vegetables, bad fruits. Maybe it was a bug or some type or something like that. That's actually one of the leading causes of people developing diverticulitis. Irritable bowel syndrome or irritable bowel disease. Again, this is mostly due to poor food habits, poor diet habits. They eat something that doesn't agree with them. It could be red meat, like I said, it could be red sauce, it could be whatever it is, just doesn't agree with their body. Their bowels become inflamed, and essentially they have to go use the bathroom almost immediately. Um, it's almost like a very severe bloated feeling with severe pain. This could be people with IBS or IBD will generally know they have it unless it's a new onset. And in that case, we're not going to truly know what's going on with them. We're going to treat their symptoms. We're going to treat their pain with what's going on. What you'll notice is a lot of these GI problems, again, they present the same symptoms. Some are caused by bacteria, some are caused by food habits, some are hereditary, such as Crohn's or um, as to where your ulcerative colitis could be developed by foods that you're eating, higher acid contents. As far as differentiating in the field, probably not unless the patient has a medical history of it. Bowel obstruction, I shouldn't have to tell you about a bowel obstruction. Common causes, foreign bodies, believe it or not, that happens more often than not. Gallstones, tumors, potentially blocking a pathway or creating pressure to not allow bowels to do their job, their intestines to do their job, or a bowel infarction. What I mean by a bowel infarction, again, our bowels or our intestines are supplied by our mesenteric arteries. We cut off the blood supply to those mesenteric arteries, and we can have a part of our bowel that essentially dies because it's not receiving oxygen, it's not receiving energy. If that happens, they might have to go in and actually remove part of the bowel um, and almost like stretch it out. Or, I don't, we have a ton of intestines within us, but they'll take a part of it out and they'll try and essentially stretch it to cover the part they removed just to so our bodies can function like normal. Hernia, obviously, we've got a looped bowel here. It's going to be really hard for waste to get through that or food to get through that. and it's eventually probably going to lead to a bowel obstruction. Another example, except our intestine now has essentially tied itself. Again, that's going to lead to a bowel obstruction. What's going to happen is that my concern with this is that we're going to get a perf bowel. It's going to, withstand so much pressure until it ruptures. And now we've got a big issue, because now we've got massive amounts of infection. This patient's going to have a distended abdomen. These people are going to get really sick if they get a bowel rupture. I wouldn't worry so much about remembering these Latin words here. Ileal volvulus. I wouldn't get too involved in remembering that. Most common spot for obstructions is for small intestine, just because, again, the diameter, as opposed to our large intestine, which is used to can actually stretch. Our small intestine can stretch, but to a point. That's where large can stretch a lot further. When we potentially encounter a patient with a bowel obstruction, I wouldn't say it's going to necessarily be a chronic issue, because if it's more of a chronic issue, I don't know that they're going to be calling 911. They're probably going to follow up with their primary care physician, or they'll know what's going on at that time. Ours are going to be more of an acute onset, where this could be, a bowel that's essentially tied itself. We have a hernia, ingestion of a foreign body. Maybe somebody's swallowed something they shouldn't have, or I hate to say the other way, just things to consider. Generally, these patients will be vomiting just because their body isn't able to process anything out, any waste out. So it's trying to essentially rid its stomach of any contents to try to make room. So these patients will be vomiting. Again, they'll be potentially have a fever. If going on long enough, they could be developing sepsis just due to the infection within their intestines itself. Bowel sounds isn't a bad thing to get in the habit of listening to, especially with people with suffering these abdominal emergencies. Listen to their bowels. Do you hear the bubbling? You hear that gurgling? That means that things are moving like they should. Where we hear absent bowel sounds, becomes a little more terrifying, and that's something I would report to the ER, especially when you're giving your report. Hey, patient was complaining of this. We listened to bowel sounds. Bowel sounds were active. Or bowel sounds were not active. I did not hear any bowel sounds, because that's one of the things they're going to listen to. If you have a Doppler, listen with your Doppler. It doesn't hurt anything. Or just listen with the stethoscope. Mesenteric ischemia, I know I talked about this. The artery that supplies our intestines, just be careful. These patients can, essentially like a heart attack, it's cutting off blood supply, it's cutting off oxygen. These patients can have an infarction within their bowels. Presents just like kind of, I wouldn't say a STEMI. They're going to be pale. They're going to be sweaty, nausea, vomiting, potentially diarrhea, maybe not. I mean, it could even be an obstruction because their bowels aren't working like they should. Bowel over time becomes ischemic, so it has that lack of oxygen. Eventually, that leads to the infarction, which leads to injury and death of that muscle. Any muscle that's without oxygen eventually dies. Think of our brain. If we go without oxygen for so long, brain cells start to kill off. Same thing with our heart. We see ST elevation. That's due to potential injury starting to form. We see ST depression. That's ischemia. Same thing within our bowels. All of our organs need oxygen to function. Appendicitis, really common, especially in young males. Our concern is a potential appendix rupture. There's nothing we can do, but getting those patients to the hospital rather quickly is pretty key. If they're presenting with right lower flank pain or right lower abdominal pain, appendix comes to my mind automatically, especially if they're younger. And I say more in males, but again, females, that can happen as well. But younger females, there's other things to consider as well. When we get into like OB the next semester, that'll make a little bit more sense when we start covering some of those potential causes or disease processes. But appendix, no known anatomic or physiologic function. Yeah, it's useless. That's what they're saying. Once it becomes swollen, again, over time, this can lead to a rupture. That's why these patients generally, again, fetal position to prevent any sort of stretching because it's causing them a ton of pain. Common site of pain, I would remember this. McBurney's point, 1 to 2 inches above the iliac crest along direct line from anterior crest to umbilicus. Okay, that was very informative. Let's hope they have a picture. Yep, okay. So essentially, right anterior hip area is McBurney's point. That center is going to be their umbilicus or the belly button. So just to the patient's right and down from their belly button is McBurney's point. But again, I would remember that if I were you for testing reasons. Remember, when you're looking at the patient, it's not your right and your left. It's as if, the patient was turned around and you were looking at their back, their right and their left, their anatomical position. If the appendix does rupture, again, they're going to be feeling a tearing-like sensation. That's something we should be cognizant of, especially if these patients look like crap and are starting to go downhill. Maybe their appendix did rupture. Palpate for rebound tenderness. That was nothing that I was ever taught, I'll be honest with you. Yeah, they were taught that you can check for rebound tenderness, especially when you're palpating. And, I can't remember the way they put it. I'll have to ask Cheryl because she's old school. She'd know that 100% better than I would with rebound tenderness. When you're palpating, if you get to that McBurney's point and they're having severe pain, don't push any further. I never understood the people that, okay, you're having pain here. Yeah. Okay. Tell me when it hurts and keep pushing. No, they're having pain there. Stop pushing. How about that? Especially if there's a potential for something being ruptured. Symptoms. Treat your patient's symptoms. I can't say that enough. How is your patient presenting? Treat it. Not the monitor. Yeah, your patient looks pale, their blood pressure's low. Okay, I'm looking at the monitor for blood pressure, but they're presenting like somebody that's hemodynamically unstable. They're pale. Maybe their pulse is weak. I should be looking at treating them aggressively with fluids if need be. Cholecystitis, again, gallbladder pain or gallbladder inflammation, generally caused by really fatty meals. I'll never forget, after I learned about this going through paramedic school, I was doing time in the ER, and they had a guy come in with severe abdominal pain. I mean, he was a pretty big guy to be like, and I don't mean like severely overweight. Just, I don't know. He was probably 6'7", 6'8", probably weighed 300 pounds. He was just a massive man, and he was having severe abdominal pain. Well, found out that he had done like some food challenge or something like that. I can't remember exactly what it was, but it was a giant cheeseburger that he ate. So the doctor said, I'm leaning towards some sort of gallbladder pain or some sort of gallbladder issue. So we're going to run some labs and stuff like that. And it ended up coming back and being cholecystitis. And I actually ended up knowing the guy. That's why I think I really remember it. Gallbladder, you can see here, it's kind of positioned right in front, kind of tucked in with our liver on the patient's right side. I'm not going to beat this dead horse on cholecystitis.
Okay, I have another question.
Yeah.
So why does it seem like it's very common when after a woman gives childbirth to end up actually with appendicitis or gallbladder problem?
That's a really good question. I don't know. I really don't know the answer to that.
I know it's very common. I've seen it before and had numerous patients that have had it, and I'm not sure why.
No, that's it. Yeah, that's a valid question. I'm not 100% sure. That's something I'd probably have to ask, maybe on somebody up at Mercy.
Okay.
I can send an email and let you know what they say.
Yeah, I mean, I know it sounds funny, but I've had like 10 friends that have kids that have had it happen like within like a month or two of birth.
Well, and I know next semester, and this might be a question for them, next semester for your guys' OB, I actually have the educator from labor and delivery coming down to teach the class. And honestly, your guys' class for the online part might be her recorded lecture as she's covering all that stuff. So That might be a question I ask her. Cholecystitis, distension, and ecchymosis. Ecchymosis is a fancy medical term for bruising. Distension and bruising are rare. That's because there's no bleeding. This is essentially just a really hurt organ. It does not like high contents of fat. Hence the reason people that eat really fatty foods develop right lower quadrant pain. It's because their gallbladder, or right upper quadrant pain, it's because their gallbladder is inflamed due to the fat content. Murphy's sign, maybe another one to consider. Diffuse right-sided tenderness or point tenderness under the right costal margin. So generally it's saying on the right side of their abdomen, if they're having diffuse pain, referring to the gallbladder, it's called Murphy's sign. Pre-hospital treatment, palliative, meaning keep the patient comfortable. Pain meds if need be. Pancreatitis, most often, I'm going to tell you right now, yeah, caused by alcoholism. I only know that because my grandfather had developed pancreatitis and then eventually pancreatic cancer just due to chronic alcoholism. Makes up for 80% of the cases. Pancreatitis, if left untreated, can lead to the patient essentially kind of like liver failure starting to jaundice, and it will actually start to affect their liver as well when their pancreas isn't able to do their job. That's why in chronic alcoholics, we're giving them vitamin B12. I know I brought that up before, in addition to dextrose, because we want that B12 to help the pancreas that's suffering absorb that dextrose. This is the reason why. Mortality is high, 30 to 40% due to potentially sepsis. In my grandfather's case, he did not want to get treated at the hospital at all. It ended up, I'm not saying it turned into pancreatic cancer, but he had pancreatitis on top of pancreatic cancer and just kept on hitting the booze, and it didn't really end well for him, unfortunately. Most of the time, what you'll see with these patients that are severe alcoholics or have a problem with chronic alcoholism is that, unfortunately, a lot of them won't seek the treatment they need to help identify or help treat their issues with their pancreas. And it'll start to lead to blood sugar issues, insulin production issues, insulin storage issues, and could ultimately lead to some type of pancreatic cancer. Spleen, stomach, remember that's the SS in my glass on the patient's left side. And your pancreas is going to sit right there on the back side of your stomach. You can see it's intertwined with different organs: stomach, spleen, and even liver. These patients will become septic after a period of time. The sepsis, they can fight with antibiotics for so long, but unless the patient stops the lifestyle or changes their lifestyle, such as, drug abusers, chronic alcoholics, unless they decide to change their lifestyle, it's not going to end well for them, unfortunately. Again, these patients are generally ones that you see jaundiced, like severely jaundiced, because it's now backed up and it's starting to affect their liver as well. Oop. All right, that was a lot shorter than I thought. Like I told you guys, it's going to be, a lot of these are going to be short nights, which I don't think you guys hate, and I think you're okay with that because I've kept you guys for some long nights. What questions can I answer for you folks? And Tanya, I'll have to ask about that because that I'm not sure. So I'll send an email tonight to somebody I know at Mercy just to kind of get their feedback on it.
No, thank you very much. Actually, you've asked my questions already until we find out, so I'm good.
When it comes to abdominal emergencies, it's kind of bland, I'll be honest, because a lot of it we can't identify in the field. but our assessment of where the pain is at could kind of help us determine what might be going on. A lot of times we like to classify a lot of things as appendix pain when it's not necessarily. Um, Gallbladder pain is more common than we think with the people eating high contents of fat, especially, I hate to say it, in the world we live in today where it's cheaper to buy a McDonald's meal than it is a bag of lettuce. Um, that's something that we'll commonly see. It's something that you most often will see. Obviously, with our elderly patients, we're more likely to see some of the bowel issues. Um, Even with some of the younger people, such as Crohn's disease, ulcerative colitis, whatever it might be, you just got to be really cognizant and paying attention to what they're complaining of, and what are you going to do for an assessment? Are you going to palpate? Are you going to listen to bowel sounds? What questions are you asking? Have they been vomiting up blood? What does their vomit look like? How long has this pain been going on? Are you on any new medications? Have you been eating anything you shouldn't be eating? Those are all pertinent questions that we should be asking these patients to help determine what's going on. A doctor can't diagnose them with that either without running tests, without running labs to determine what's going on with inside their body. So don't feel like, well, I feel like I didn't learn a whole lot about abdominal emergencies, because you didn't. Our what we primarily focus on is our assessment. When we're talking about, Murphy's point, McBurney's point, that's just helping us identify things there during our assessment. It's not telling us what's wrong with them. It's telling us what potentially organ could be involved. Any questions?